The following podcast is part of a certified educational activity titled Progress and Practicalities in Immunotherapy Biomarker Testing and Pathologic Response Assessment in Solid Tumors, What's New and What You Need to Know and Do. Access the entire activity and complete the post-test at peerview.com/KCV860. Downloadable slides and practice aids are also available.
Good morning and welcome everybody to this breakfast meeting about progress and practicalities in immunotherapy biomarker testing and pathologic response assessment in solid tumors. What's new and what you need to know and do. So today we have a very interesting panel of speakers, the first of which is myself, and then Dr. Jonathan Rees. He's a medical director of thoracic oncology and associate professor at UC Davis. And we have Dr. Zeb Weinberg. He's a professor of medicine and surgery here at UCLA, and he's also involved in early phase clinical research program. Okay, and you can also visit us online at the address indicated there. You can view all the slides, the practice aids, and also download the content from the event. So please enjoy yourself in person and virtually. So now we're going to discuss a little bit the topic. First, we're going to review how to keep up with the rapid, vertiginous progress of immunotherapy, biomarkers, and pathologic response assessment, which is an emerging situation that we're facing more and more. Then we'll look at the oncology stake. First, we'll look at the role and use of immunotherapy and biomarkers in practice, focusing first on lung cancer, which will be addressed by Dr. Jonathan Rees, and then on GI cancers, focused by Dr. Weinberg. And then finally, we'll close with the pathology stake, and we will discuss how to implement and operationalize biomarker testing using as examples PD1, microsatellite instability, tumor mutational burden, and then we'll do a quick look into the future. So the first part, we'll talk about how this is moving, and I'll be in charge of this. And really what's happening with immunotherapy is fascinating and concerning. Fascinating because over the last 5 years or so, we have seen massive progress in the number of treatments that are available to patients, the number of indications in which these therapies have been approved, but also in the emergence of biomarkers that are able to somewhat inform about the likelihood of this patient to respond. Despite all this progress and the time lapse, there are still major challenges, including, for example, how to handle PD1 as a biomarker. There are a number of issues, some of which are indicated in the slide. But also newer biomarkers that have been already approved, like tumor mutational burden, but we know very little about, and it's very difficult to implement and report. So despite this topic being not so new anymore, there are a number of questions and challenges, some of which we're going to address here. And then the mainstream of immunotherapy today at the clinical level, it's based on two major pathways that are indicated in the slide. The first is the CTLA-4 pathway, which is on the left side of the slide, and which is essentially an immune inhibitory receptor that is present on activated T cells. And these activated T cells upregulate or put this CTLA-4 receptor in the membrane, and the blockade of this receptor can actually inhibit the inhibitory signal and therefore restore or activate T cell activation. We believe that this effect occurs mostly on the T cell priming stage, so maybe outside the tumor bed in secondary lymphoid organs, but it's unclear if there is also a role in the effector stage in the tumor bed. The second pathway, and arguably the most impactful one, is the PD1 PD-L1 pathway, which is on the right side, which is a similarly conceptually mechanistic view. Essentially, it's another inhibitory receptor that gets upregulated in the surface of activated T cells, that it's an inhibitory receptor, and therefore blockade of this receptor is able to reinvigorate T cells to recognize tumor. However, this pathway, it's believed to be more relevant in the effector stage in the tumor bed rather than in the priming stage outside the tumor microenvironment. But again, there is not complete certainty about the relative function. So these are the two sort of main pathways, and there are a number of agents that can actually selectively block these receptors and therefore mediate an immunostimulatory anti-cancer response. As I mentioned, the impact of these therapies have been massive, and there are a number of indications and growing indications where PD1 agents alone or in combination have been approved. And you can see in the slide just a number of indications where there is at least one monotherapy approval. So you can see that really spans nearly the whole spectrum of medical oncology and pathology practice. So really, this has been very, very impactful. But then over the years, there have been developments of combination therapies that try to capture different mechanisms of action and sometimes even synergistic effects. And you can see that numerous combination therapies with PD1 agents alone or in combination with targeted therapies, chemotherapies, or even tyrosine kinase inhibitors have been already approved and are in use in multiple different tumor types. And this has raised a number of questions on how to select patients for these therapies. When there is a monotherapy option and a combination therapy option, is there a way we can identify the patient who is most likely to benefit from one or the other? Which brings us again to the need to have biomarkers to use these therapies wisely. Similar to the clinical landscape, the landscape of biomarkers have been quite complex. And this is a slide that summarizes a number of metrics that have been somehow associated with likelihood of response to these PD1 inhibitors. On the upper side, you can see most of what I call the phenotype or immune-related markers, which include all the way from simple PD-L1 immunohistochemistry or tumor-infiltrating lymphocytes to very sophisticated measurements of interferon gamma responses, myeloid responses, and even the gut microbiome. Many of these are not completely understood, and they're being progressively developed and somewhat implemented. And then there is a whole layer of what I call genomic of tumor cell biomarkers that include generally DNA-based genomic metrics, such as microsatellite instability, tumor mutational burden, but there are also discrete mutations in genes that are associated with higher or lower likelihood of clinical benefit, and then there are tumor cell-specific additional genomic metrics. So as you can see, this is a very complex landscape, and many of these currently are only metrics, not biomarkers, because to move from metric to biomarker, they need to pass a number of clinical steps. Today, from all of this list, we have 3 biomarkers that have been clinically approved. One that I considered immunologic, although it's scored frequently on tumor cells, which is PD-L1 immunohistochemistry. And then we have microsatellite instability and tumor mutational burden. This is where we are today, and we will discuss these 3 biomarkers in depth. So the other incredible situation that has happened over the last few years is the amazing increase in the movement of all these therapies to the early stage, which makes a lot of sense, because in general in cancer, the earlier the better. But just as an example, you can see here a number of approvals of therapies, PD1 agents or CTLA-4 blockades in the context of adjuvant and neoadjuvant therapy. And you can see here that they span a number of different tumors. And this is, again, adding pressure to our pathology suites to be able to handle this neoadjuvant type of pathology, which is slightly different from what we do with advanced stage, where we generally get small biopsies. So we'll also discuss the example of lung cancer. And these are, again, more approvals. You can see that essentially every agent, nivolumab, pembro, ipilimumab, atezolizumab, each of them have recently received approval in an earlier stage setting, which is impacting the way we actually practice. As pathologists, we are typically asked to handle samples in the neoadjuvant setting, but there is actually not a lot of guidance on how to do that. And the difference may be actually tumor-specific, or there may be even histology-specific. And we will try to address some of those concerns today. But in general, I think as a concept, the most important thing is that pathological response is generally associated with survival. And that's why it's an attractive endpoint to be able to query the response to treatment and also assess what to do after the patient has been treated in that setting. And in general, we can say that major pathological response accounts for those situations where less than 10% of the viable tumor cells are detectable on pathologic examination. And then there is another concept called pathologic complete response, which is essentially the absence of tumor cells detectable in the expected tumor bed. These definitions are not set in stone. They're actually being revised and updated regularly. And as I mentioned, they may be tumor type specific and even histology specific. So this is just a reference, but we need to keep an eye on further guidelines and developments. The other interesting things is that recent data has suggested that some of these metrics may be actually treatment dependent. And I will touch briefly on that relative to the effect of immunotherapy, targeted therapies, or chemotherapies, and how they can actually impact the specimen. The other important consideration is that over recent time, a number of additional immune inhibitory receptors, or so-called checkpoint receptors, have been also developed further clinically. And there are a number of co-stimulatory signals that are indicated here on the left side of the lymphocyte for which agonistic antibodies can actually produce immunostimulatory response. And many of them have been tested in clinical trials, such as OX40, GATOR, 4-1BB, or CD137. But there is also additional immune inhibitory receptors that can be blocked, perhaps on top of some of the known actionable immune inhibitory checkpoints. And there are many, such as TIM3, LAG3, VISTA, and a few others. But the most important thing is that some of them have already become standard of care. And as of a couple of weeks, actually, LAG3 became FDA approved in combination with anti-PD1. So this is just to show how dynamic this is and how we need to keep an eye on these developments. This is just a little summary of this LAG3. The drug that was FDA approved is called Relaplimab, which is this monoclonal antibody that was approved to use simultaneously with nivolumab. So essentially, it's PD1 LAG3 combination therapy, and it blocks in a conceptually similar manner. So this Relaplimab antibody is able to block the interaction between the inhibitory receptor LAG3 on the T cell, and then its ligands, both of which are at this point FGL1 and MHC class 2. So the blocking of this interaction ultimately stops this inhibitory signal and further stimulates T cells to recognize and kill tumor. What are going to be the biomarkers for this LAG3? We still don't know. It's being developed, and I'll briefly touch on that at the end of the presentation. But just keep there, because this drug is being tested in other tumor types, and there are other agents being developed. This is just a summary to tell you that what we are discussing today are T-cell-centric therapies, okay? So essentially, we're looking to reinvigorate T cells to recognize tumor, but there are a number of other immune cells that can potentially be harnessed to either stimulate T cells or kill tumor cells directly. And this cartoon highlights some of those cell populations. You can see that there are Tregs that can be suppressed. There are myeloid cells, there are myeloid-derived suppressor cells, vascular cells, and other things. So really, the complex of immunotherapy is spanning way more than just T cells, and we should expect to see additional developments in the coming years. There are at least 2 other therapies that have shown some level of benefit in the context of trials. There is, for example, a TIGIT inhibitory antibody that has activity in lung cancer, again in combination. And there are also therapies targeting immunosuppressive enzymes such as CD73. And we heard last year at ESMO from one very interesting result using an anti-CD73 combined with an anti-PD-L1 durvalumab. So again, this is expanding quite rapidly. And finally, there are not only immunotherapies in the form of antibodies that can modulate cells in the tumor microenvironment. There are a number of other forms of immunotherapy that have been actively developed. And just to mention modalities, so within each of these, there are a number of options, but we have anti-cancer vaccines, even neoantigen-specific vaccines being developed. We have adoptive cell transfer, essentially with autologous T cells or even modified T cells, such as CAR T cells. And then we have BiTEs and bispecific antibodies and antibodies that can target multiple signals at a time, oncolytic viruses, and then finally, what we have already discussed, immunomodulatory antibodies and cytokines. So this is very, very exciting, very, very sophisticated, and immunology is going to be with us for a while. So now, as a summary from this part, I think we have learned that immunotherapies target at least CTLA-4, PD-1, and now a few other immune inhibitory receptors are broadly used and induce durable benefit in a fraction of patients with cancer. But the role of biomarker testing across them needs to be established and hopefully transferred to the clinical space soon. The second important point is that biomarkers to select patients for monotherapy and combination therapies are needed, but the field is highly dynamic and it's actually very difficult to catch up with these biomarkers that are approved and then developed further and change over time. Novel immunomodulatory targets show promising clinical activity. LAG-3 is an example, but as I mentioned, there are a few others down the road, and they're very, very close to approval, so we expect to have a few more. And I mentioned there LAG-3, TIGIT, and CD73 as really good examples of this. And then finally, immunotherapies are transitioning to earlier stage, mostly adjuvant and neoadjuvant setting in patients with resectable disease. And this is putting a lot of additional pressure and excitement too in the pathology end to be able to recognize, handle those samples properly, and communicate the information to our treating physicians to be able to handle those patients well. So now we'll move to the more clinical end of the presentation, meaning therapeutic, because obviously everything is clinical. And this will be about the role and use of immunotherapies and biomarkers in non-small cell lung cancer, and this will be handled by Dr. Jonathan Rees. So please, Jonathan.
Thanks so much. So thank you for joining us on this morning program, and I'm excited to speak with you today about the role and use of immunotherapies and biomarkers in advanced stage non-small cell lung cancer. And what I want to do is build upon the fantastic overview that Dr. Schalper just presented in terms of the role of biomarkers and use of immunotherapy, and take it to some cases and show how we have moved from not just the metastatic space in terms of optimizing treatment for these patients, but also into earlier stage settings in the surgical setting, neoadjuvant setting, as well as with after chemotherapy and radiation in the locally advanced setting. And what I want to do is give a flavor about how we incorporate a lot of these biomarkers, PD-L1, TMB, mutations and co-mutations into our medical decision-making to determine the optimal therapies for our patients, because we have a plethora of options in terms of navigating treatment. And so we have monotherapy options where pembrolizumab, atezolizumab, and cemiplimab are all approved, and the approvals are based upon PD-L1 expression as first-line therapy. For example, 1% or more for pembrolizumab, but the benefit is really driven by the PD-L1 high, 50% or more. Atezolizumab and cemiplimab in PD-L1 high as well. And in addition to PD-L1 status, we look at other clinical factors such as disease burden, symptom severity, performance status, whether the patients have autoimmune comorbidities that may impact our ability to safely deliver immunotherapy drugs, patients' goals of care, and as mentioned, mutations and co-mutations. For example, patients with EGFR activating mutations, one of those kind of oncogene drivers not associated with smoking, those patients often do poorly, particularly with single-agent immunotherapy. And we have a number of combination therapies to choose from. Dual immune checkpoint blockade with nivolumab and ipilimumab, as well as chemotherapy and immunotherapy combined. And so in terms of PD-L1 testing requirements in advanced metastatic non-small cell lung cancer, many of you are familiar with the companion PD-L1 IHC assays that go with these respective immune checkpoint inhibitors. 22C3 and 28-8 have been shown to be comparably similar in results, and SP142 for atezolizumab with the Ventana TC IC assay. Now, as mentioned, one of the most pivotal studies in non-small cell lung cancer was in the metastatic setting, which is the KEYNOTE-24 study that showed in patients who have PD-L1 high tumors with metastatic non-small cell lung cancer, you could see a strong separation of pembrolizumab with improved survival compared to chemotherapy in the Kaplan-Meier curve. And this was a pivotal practice-changing study for us. So then there was the KEYNOTE-42 study that said, well, let's take PD-L1 positive defined as 1% or more, not just the PD-L1 high group. And that also was overall a positive study, but as you can see in the Kaplan-Meier curves broken down by PD-L1 immunohistochemistry, the greatest magnitude of benefit was the 50% or more, just highlighting how that PD-L1 high subgroup is a special subgroup that has high response rates and improved progression-free survival and overall survival to single-agent immunotherapy compared to chemotherapy. So then we evolved to combining with chemotherapy. And so I would highlight this is for non-squamous metastatic non-small cell lung cancer, looking at chemotherapy with carboplatin and pemetrexed, with or without pembrolizumab. And what you can see here once again, is a strong separation of curves in terms of a dramatic improvement in overall survival. At 2 years, overall survival was 45% in the patients who received immunotherapy with chemotherapy and 27% without, so a large difference. Overall survival broken down in the panel on the right by PD-L1 TPS, you could see that PD-L1 low subgroup and PD-L1 negative subgroup also substantially benefited with improved survival with chemotherapy and pembrolizumab. Therefore, this has become a standard of care for those patients who are PD-L1 low. Whereas for patients who are PD-L1 high, either chemo or immunotherapy or pembrolizumab is used. And some of our differentiating factors include things, as I mentioned before, thinking about disease burden, the presence of co-mutations that may be a poor prognostic factors in terms of benefiting from immunotherapy and so forth. And in squamous non-small cell lung cancer, we saw similar results. This was the KEYNOTE-407 study, which is the squamous histology doppelganger of KEYNOTE-189 that used a different chemotherapy backbone pertaining to squamous lung cancer, either with or without pembrolizumab. And you could see here, once again, a dramatic improvement in overall survival and progression-free survival that was observed irrespective, once again, of PD-L1 status, higher response rates, improved progression-free survival, improved overall survival. I would just highlight for our metastatic lung cancer patients, we recently published about a year ago that in that KEYNOTE-24 study, for PD-L1 high patients with first-line immunotherapy, the pembrolizumab, the 5-year overall survival was about 33%, so a third of patients. And if you go back a decade or so ago, that was about 5%. So we need to do better, but it's been a dramatic sea change in terms of the clinical improvement and survival we're able to bring to our patients, particularly in the subsets that benefit from immunotherapy. As mentioned, there are combinations. There's the nivolumab, ipilimumab, dual immune checkpoint blockade. Dr. Schopper went through the mechanism for CTLA-4 and PD1 and PD-L1 inhibition, and here you could see compared to chemotherapy alone, looking at these Kaplan-Meier curves of nivolumab and ipilimumab, the dual ICI versus nivo and chemo, PD-L1 1% or more. There was this overall survival benefit of the dual immune checkpoint blockade compared to chemo, as well as looking at the less than 1%. It's approved by the FDA for 1% or more, although the data also looks good in terms of the PD-L1 negative, particularly with high tumor mutational burden. So with that in mind, let's consider a case. So a male, age 69 years old, former smoker, 15-pack year smoking history, good performance status, presented with fatigue, weight loss, diffuse pain is suddenly worsened. He has a 3.5 centimeter lung lesion, right lower lobe, bone metastases, adrenal metastases. A biopsy shows lung adenocarcinoma, no targetable genomic alterations, PD-L1 high, 60%. And what would we do? As mentioned, the options are single agent PD-1, pembrolizumab, cemiplimab, and atezolizumab approved in this setting. That is a good option for these patients. As mentioned, if you need a response, oftentimes chemotherapy added to immunotherapy can improve response rates, so we think about doing that. They've actually haven't been compared head-to-head in terms of, for example, pembrolizumab with chemo and pembrolizumab for PD-L1 high, but they're ongoing trials. So that's how we generally manage those patients. If it's PD-L1 lower, as mentioned, chemotherapy and immunotherapy, less than 50% is generally our standard. For PD-L1 1% or more, nivolumab and ipilimumab is also an option, but it actually was with pembrolizumab was compared to the pembrolizumab and ipilimumab for PD-L1 high and shown not to be any different in terms of outcome, and it's more side effects. So therefore, for PD-L1 high, either chemoimmunotherapy or pembrolizumab or similar approved PD-1 or PD-L1 agent alone. So this is how we think of making decisions for our patients. As mentioned, we also look at co-mutation status that may be poor prognostic factors, for example, KEAP1 and STK11, also known as LKB1. Also look at things such as tumor mutational burden that we'll discuss further. And I would also highlight now what we do is now that we have such great data in the metastatic setting, we've brought that up to earlier stage settings. So this is the Pacific trial that was done in locally advanced non-small cell lung cancer that was unresectable. This is the 5-year update. And so these patients for stage 3 non-small cell lung cancer received chemotherapy and radiation followed by consolidation durvalumab, which is a PD-L1 antibody for the duration of about 1 year. And you could see once again, 5-year overall survival, substantially improved, statistically significant from about 43% to about 33%, wide separation of these curves, and this has been a sea change in terms of how we treat locally advanced unresectable non-small cell lung cancer. I would highlight that it appears that PD-L1 positive patients in the subset analysis did better than PD-L1 negative patients. It is approved in the US regardless of PD-L1 expression, and that's how I give it to these patients, although I would note in the European Union, it is approved for just PD-L1 positive patients based upon that subset, but the overall study was positive regardless of PD-L1 status. Now, what we do in medical oncology is we have these big advances, and then what we do is, as part of our ranking, ordering, and sorting and combining, bring it to earlier stages. So we talked about the metastatic setting, we talked about the locally advanced unresectable setting, and what's really exciting now, and what we're getting readouts of multiple studies, is the earlier stage surgical setting. And so, this really began with Dr. Ford and colleagues and others who looking at neoadjuvant nivolumab and other similar immune checkpoint inhibitors in patients with resectable non-small cell lung cancer. And you can see here in this study, there were major pathologic responses in 9 out of the 20 resected tumors. You could see in the plot below the depth of pathologic response and regression. And these responses occurred in both PD-L1 positive and negative tumors. So this was really exciting to see in terms of major pathologic response in patients treated with neoadjuvant nivolumab. Interestingly, radiographic response is not necessarily predictive, where there can be, for example, in the panel on the left, you can see the pathologic CR in a patient in tumor residual nodal disease, and then in another patient, the scans with a pretreatment and resection specimen showing 90% tumor regression. So may not exactly correlate in terms of having the changes in the immune microenvironment, which may not be reflected in the follow-up radiographic imaging studies. Now, there are multiple studies of multiple PD-1, PD-L1 immune checkpoint inhibitors in the neoadjuvant setting before surgery, looking in combination, including with combinations of chemotherapy. So our standard practice for patients with stage 2 or 3 non-small cell lung cancer that's resectable has been to do the surgery and then give 4 cycles of adjuvant cisplatin-based chemotherapy based on an improvement of overall survival in multiple clinical trials of about 5%. So we also found doing these studies that giving it before surgery or after with chemotherapy didn't make too much of a difference, but our convention had been to give it after. But now, given the nature of kind of immunotherapy being and giving it before, in terms of having the tumor there, there's been a lot of movement to give the chemotherapy with immunotherapy up front. So as mentioned, multiple trials with multiple agents, PD-1, PD-L1 drugs in combination with chemotherapy. Now, the one that's very exciting that was recently FDA approved is the Checkmate 816 study. So this was a clinical trial looking at stage 1B to 3A operable non-small cell lung cancer with good performance status patients. Patients were randomized to receive chemotherapy with nivolumab, dual ICI with nivo and ipi, or platinum doublet chemotherapy. I'm going to focus on the platinum doublet chemo versus nivo chemo arms. Primary outcome of event-free survival, as well as pathologic complete response. secondary outcomes of overall survival and others, overall well-balanced population. And as you can see here, a substantial improvement in the co-primary endpoint of pathologic CR rate, 24% with immunotherapy and chemotherapy versus chemotherapy alone of 2.2%. And so based on that being dramatically improved, with the Nivo-Ipi arm having less, that this was focused on for the further portion of the study. You could see nivolumab and chemotherapy, the depth of response in the tumors much greater compared to chemotherapy alone. And you can see that represented graphically here. Median viable tumor cells were 10% in the chemo-nivo arm and 74% in the chemo arm. And broken down by stage, you could also see just a dramatic difference with the addition of nivolumab added to chemotherapy in pathologic CR rates compared to chemotherapy alone, 40% for 1B, and in the mid-20s for 2A to stage 3A, as mentioned, much less for chemotherapy alone. And what's really exciting now is, well, does this translate to a survival benefit? Does this translate to an event-free survival benefit, preventing the cancer from coming back? And the answer is yes. So in terms of the other co-primary endpoint, in terms of event-free survival, the hazard ratio was 0.63, highly statistically significant. Median event-free survival, 31.6 months versus 20.8 months. This included patients who were both PD-L1 negative and PD-L1 positive. And on March 4th, the FDA approved nivolumab with platinum doublet chemotherapy in the neoadjuvant setting for adult patients with resectable non-small cell lung cancer. I would note this data has yet to be fully presented yet and will be presented at the upcoming AACR meeting in April, where we look forward to taking a look to diving into the data in terms of PD-L1 expression and outcomes and other factors of patients who may preferentially benefit or not. The other study I also want to discuss in the early stage setting was the Empower010 study. And so this was, as mentioned, our convention prior to Checkmate 816 was to do surgical resection followed by chemotherapy. And so this study randomized patients, similar patient population, stage 1B, 4 centimeters or more, to 3A, resectable non-small cell lung cancer, to get surgical resection, chemotherapy per our standard, and then patients randomized to the PD-L1 immune checkpoint inhibitor atezolizumab versus best supportive care. The primary endpoint was investigator-assessed disease-free survival, and they did a hierarchical statistical testing in terms of their statistical design, going to disease-free survival for PD-L1 positive, defined as the TC 1% or more for 2 to 3A patients, and then if positive, to look at all randomized population, and then go to look at intention to treat, DFS, and then overall survival. I would highlight, looking at the first portion of their hierarchical testing, the panel on the left, you could see in patients who had stage 2 to 3A resected non-small cell lung cancer, PD-L1 positive, TC 1% or more, you could see once again disease-free survival dramatically improved by about 13%. Looking at the all randomized population, there also was a benefit, although less of a separation of curves. And I would note in the randomized 1B to 3A, there was a trend towards benefit, although statistically it did not meet the threshold boundary for disease-free survival. So based upon this data, atezolizumab was approved after chemotherapy and resection for stage 2 to 3A non-small cell lung cancer, PD-L1 positive 1% or more. And so this was with the Ventana PD-L1 SP263 assay as a companion diagnostic. And on October 15th, it was approved for adjuvant treatment for platinum-based chemo for 2 to 3A whose tumors have PD-L1 expression of 1% or more of tumor cells as determined by an FDA-approved test. So that was another significant advance. So now we have approvals both in the neoadjuvant setting and in the adjuvant setting. And then most recently, as of last week, there was the PEARL study, which looked at pembrolizumab, which is a PD1 immune checkpoint inhibitor in terms of in the post-surgical setting after surgery and chemotherapy. So a similar study to the Empower010 atezolizumab study. And overall, as you can see in the Kaplan-Meier curve on the bottom left, there was statistically significant improved disease-free survival, median DFS of 53.6 months versus 42 months. This also included patients who were PD-L1 negative. As mentioned, Empower010 was the approvals for PD-L1 1% or more. For these trials, the overall survival data are immature, but that's our ultimate goal, is to improve overall survival. And in this study, once again, there's some interesting data with the subset analysis, but overall the study was positive. So in terms of clinical practice, what to test in non-small cell lung cancer. For metastatic disease, PD-L1 testing is essential, and also broad genomic profiling for non-squamous non-small cell lung cancer, and for a lot of squamous non-small cell lung cancer, scant tissue specimens, patients who don't have a large smoking history, broad genomic profiling with NGS is standard. For 1B to 3A, as mentioned based on these studies, PD-L1 is recommended, as well as EGFR mutations testing, as those patients are unlikely to benefit from immunotherapy, but broad NGS is preferred, as mentioned, to inform our clinical decision-making in terms of some prognostic factors of mutations and co-mutations that may be of benefit or lack thereof.
Okay, now we'll move to the third part of the presentations, and now we're going to move to the role of and use of immunotherapies in GI cancers, focusing mostly on upper GI, gastroesophageal, and this will be taken by Dr. Seb Weinberg. Please.
Thank you, and thank you, Kurt and PureView for having me. So in GI cancers, we know this runs the gamut from extremely heterogeneous group of diseases like gastroesophageal cancer to extremely what we called immunologically cold tumors like pancreatic cancer. So by and large in GI cancers, there's not as big a role of these drugs as there is in lung cancer, like you just heard. The outlier has been so far gastroesophageal cancers, and we'll go over some of that. And because within the esophagus and stomach, this is in fact a very complex group of diseases molecularly, very heterogeneous, as you could see here. It runs anything from an entirely different squamous histology, which is primarily an esophageal cancer in the upper part of the esophagus, which is mostly in Asia and Southeast Asia, versus what we tend to see in the Western world, which is more gastroesophageal junction adenocarcinoma, proximal stomach cancers, versus what is also seen back in primarily Southeast Asia, which is distal body stomach cancer. And each one of them has different molecular subgrouping and in fact behaves clinically differently and responds to treatment differently. The big distinction on a epidemiology level is listed here. Esophageal squamous cell carcinoma is a little more common, quite a bit more common, in fact, one of the most common cancers in the world in Southeast Asia, which has typically been associated with smoking and alcohol. About half of the patients have what we would consider to be positive expression of PD-L1, primarily on the cancer cell surface, whereas adenocarcinoma of the esophagus and distal esophagus and what we would call the gastroesophageal junction is a very different disease epidemiologically, and also is associated with a much lower expression level of the PD-L1, at least by immunohistochemistry. So here's our typical case. We have a patient who has a 70-year-old woman with metastatic gastroesophageal junction, adenocarcinoma. What testing, baseline testing, ought to be done at baseline, at diagnosis of metastatic disease, to understand the biology and inform the treatment planning for the oncologist. And, you know, I look at it as we have a minimum of 3 things that we now ask all of our patients with gastroesophageal cancer to have when they walk in the door with advanced disease. One of them is HER2, and this is not the subject of today's program, but certainly HER2 has been standard in gastroesophageal cancer for about 10 years. Typically, immunohistochemistry alone is sufficient. although FISH is recommended if patients are HER2 positive. IHC for mismatch repair protein deficiency, which we'll talk about a little later. A critical element for us is understanding the role of microsatellite instability and establishing first if immunotherapy alone is an appropriate option for patients with gastroesophageal cancer. It's much less common in esophageal cancer and a little more common in gastric cancer, and of course colorectal cancer, which we'll talk about at the end. And PD-L1 scoring, usually utilized not by expression just on the tumor cell surface, but on what is we all know as combined positive score, which takes into account the reflection of PD-L1 status on immune cells in combination with tumor cells. Beyond that, we do typically send some patients out for next-generation sequencing, primarily to look at more of the obscure targets. And now, of course, as you'll start to see, as we're all starting to see, a lot more blood-based testing is starting to take over, particularly for cancers that are difficult to biopsy, like pancreatic and other GI cancers. So what we've seen so far is on the top, you'll see that we're trying to think about gastroesophageal cancer as having a pie chart with which each cancer is represented and has a subtype, similar to how these folks do it in lung cancer now for a little while. But it's a lot more of a Venn diagram than it is a pie chart. And we're going to learn over the next few years what the overlap is of all of these biomarkers, because heretofore we're still not sure exactly what the overlap is with a lot of these things. And I'll talk about two other ones that are on the horizon, and I listed them on the bottom here because you'll hear about them in the next few years. Claudin and FGFR2, and these are both drugs that have been tested in patients based on selection of patients on immunohistochemical assays that have both led to positive randomized phase 2 trials. And that means that the randomized phase 3 trials for both of these drugs, and there's several in development, are already ongoing, and many of them have been completed already. And what's interesting about those two, Claudin and FGFR2, is that they're both companion diagnostics for immunohistochemistry, not genomic-based markers at all. So protein expression on the tumor cell surface is a requirement for activity of these drugs. And so we may get even more complicated from a pathological perspective in gastric cancer than we are today as we start to select patients based on even more immunohistochemical criteria. So one of the questions in esophageal gastric cancer is, what do you do with patients after surgery? Typically for many years, patients undergo neoadjuvant chemoradiation if they have esophageal and gastric cancer, followed by surgical resection. And we did, for the first time, see a big change. For many years, after surgical resection, the standard of care was observation. We wouldn't do anything, actually. There's been no evidence that continued treatment helps in the long run. And this study, which was a landmark study in our field, published exactly a year ago, was the Checkmate 577 study, which looked at nivolumab in patients who have had surgical resection. So after esophagectomies, patients were randomized to either nivolumab or placebo for about a year after surgical resection. And the premise is based on all the data you heard earlier, that immune surveillance, particularly important in a disease like this. And this was a big, big global study. And the results here, you'll see a Kaplan-Meier curve showing a very, very compelling disease-free survival, which means some of these patients are going to be cured with the addition of nivolumab over placebo. So this led to a very quick FDA approval of adjuvant nivolumab, regardless, actually, of PD-L1 expression in the patients who undergo surgical resection for esophageal cancer. Now, we don't have 1 million studies like these guys in lung cancer who have many drugs approved and many different options. We really don't have any beyond that in early stage disease. You see here, I put a list of the ones that are ongoing. Some of these are, in my opinion, quite redundant. Some of these are, at this point, just another company trying to catch up, which isn't really moving the field forward that much, in my opinion. But some of them are adding twists to the story. For example, in the patients who don't undergo surgical resection, who aren't candidates for surgery, what do we do with those people? We're trying to answer that question. We're trying to answer the question of, does gastric cancer behave differently than esophageal cancer with these drugs? So there are some really important studies ongoing over the next few years. But by and large, the advances in gastroesophageal cancer have been in metastatic disease, which is obviously the paradigm by how we, as clinical oncologists, test drugs. We first test them in advanced disease. If they work there, we try to move them up front. If they don't work in advanced disease, then most companies will say, gosh, there's no way this would work in earlier disease, and the drugs are disposed. That's been the paradigm for many years. In any event, this was the largest phase 3 trial ever done in gastric cancer. It was published also in the last few months. And you can see here that 2,000 patients were enrolled globally. You know, and it sounds crazy to enroll 2,000 patients, but when you think about the epidemiology of gastric cancer, it really is globally one of the most common cancers. So a lot of the enrollment of these studies takes place in China, Korea, Japan, where every patient is screened for these cancers, and many patients are diagnosed, and they have a lot more experience than we do at obviously screening these patients and diagnosing them. So in fact, what we see is a huge disparity between enrollment in the Asian countries versus Western Europe and North America. But here, this study was a big global study that really focused on the bottom two arms. Chemotherapy alone, which is the standard of care for a while, which has been FOLFOX or Zelox, versus the addition of nivolumab to chemotherapy. And the primary endpoint of this study was here that was met, and it showed an overall survival improvement of 11.1 months to 14.4 months, which met statistical significance. And they basically approved the drug for anybody with gastric cancer based on the fact that they met their secondary endpoint. Now, moving on to HER2-positive gastric cancer, this is another area of interest. And in HER2-positive gastric cancer, there really isn't clearly a role to check for PD-L1 because, by and large, about 80 to 90% of patients with HER2-positive gastric cancer do have some adequate expression of PD-L1, at least by immunohistochemistry. So this study randomized patients to either chemotherapy plus trastuzumab plus placebo, or Herceptin plus chemo plus placebo, versus chemotherapy plus trastuzumab plus pembrolizumab. And the overall survival was the primary endpoint, but a key endpoint here was response rate. And you could see here that in the data set presented, which was just published recently in Nature Medicine, there is a huge improvement in response rate from 52% to 74% in the group of patients who got chemo plus trastuzumab plus pembrolizumab over chemo, trastuzumab, placebo. So this is a big response rate endpoint, which wasn't the primary endpoint of the study, but because the response rate was so sufficiently large, the FDA also made the decision to approve this combination based on an accelerated approval based on response rate without yet seeing any of the impact on progression-free and overall survival. This is what you see now is, and we were talking about this earlier, the FDA issues approvals without sometimes any peer-reviewed presentations even, just based on the data set submitted by sponsors. And it's a big sea change in how drugs are available because of the interest of the FDA in getting access for oncologists to these drugs before a long, thorough review. That has mixed implications, as we all know. In any event, this combination was FDA approved, and in truth, if you look at those data sets, it doesn't seem to matter what PD-L1 expression is, that independent of PD-L1 expression, the group of patients who are HER2-positive gastric cancer do get benefit from that combination. Now, we know that we can use some other tools, and this is just the a way to think about our patients with gastric cancer. We know that CPS-10 is even more stringent than CPS-5, and I believe that as the CPS score increases, by and large, in this disease, that's where the bang for your buck is of these drugs. We've known that for a number of years. It seems to be more common in certain TCGA subtypes, as you can see here, but most predominant has been demonstrated in a number of studies now in the MSI-high population. By and large, if we identify a patient with metastatic gastric and metastatic colon, by the way, those two, and we identify them in advance as being microsatellite instability, which is, in my opinion, the most important thing, the piece of data that as an oncologist we need to know right away, they get immunotherapy up front. They get pembrolizumab or sometimes nivolumab and ipilimumab up front. They don't even get chemotherapy if they're truly microsatellite unstable. And that's a a sea change in obviously how we treat a lot of the GI cancers. Now, colorectal cancer, and I'm not going to spend too much time on this because the subject of this program is PD-L1 and immunohistochemistry expression. And as far as we're aware, there is no value to that in colorectal cancer. None of the studies have demonstrated that immunohistochemical testing of PD-L1 has any correlation with benefit of these agents. By and large, colorectal cancer is still classified based on KRAS or RAS mutation status into RAS wild type, RAS mutated. And then now we are starting to see some subgroups tease out. For example, microsatellite instability, as I mentioned, that's absolutely critical in colorectal cancer, as Dr. Schalper will talk about. And also BRAF V600E, which is a point mutation in BRAF, is another critical actionable mutation in colorectal cancer. But we haven't seen the value of classical PD-L1 IHC testing. And in fact, across GI cancers, the only circumstance where PD-L1 status seems to be important is in gastroesophageal cancer. In pancreas cancer, of course, there's no value to these drugs. In hepatocellular carcinoma, which is where perhaps the biggest advantage to immunotherapy has been, there's no role of PD-L1 IHC because the drugs work independent of PD-L1 testing it by immunohistochemistry. So it's really amongst the GI cancers, by and large, gastroesophageal, where PD-L1 expression matters. So in general, and to look at just gastroesophageal, we believe MMR and MSI, Enhertu and PD-L1, and colorectal, MMR and MSI is the most important, RAS-RAF status, and starting to emerge perhaps HER2 status as well. We also have tumor-agnostic criteria, like every cancer, where the value of microsatellite instability is clear, the value of tumor mutational burden, perhaps more controversial, but seems to be some benefit there as well to knowing that information, and then the obscurities or the unicorns such as NTRK fusion and some of these obscurities that are only available by RNA testing.
Thank you very much, Dr. Weinberg. So now we're going to move to the final part of this session, which has to do with how to implement and operationalize biomarker testing and pathologic response assessment in practice. Here we are trying to include a number of examples so that we can have a practical view of how this works or how it doesn't work. And PD-L1, as we mentioned, has been loved and hated for quite some years now, but it actually works in some disease settings and context. So it is a tool that we have to deal with. And the fundamental biology about PD-L1 is now actually much better understood. So what we know about PD-L1, it's a ligand that is upregulated in any cell upon immune pressure. And normally it's a mechanism by which cells that are exposed to an inflammatory environment, they can shut down inflammation to actually survive or limit tissue damage. But what happens in the context of cancer is that when tumor cells are recognized by adaptive immune cells such as CD8 effector T cells, and they get to the tumor to kill it, they produce interferon gamma, which signals to interferon gamma receptors and upregulate PD-L1 in the tumor, ultimately protecting the tumor cell from this cytotoxic attack. And this is very important because, in a way, PD-L1 upregulation is concatenated with adaptive immune pressure. So the more PD-L1 is usually seen in those tumors that are more inflamed or face immune pressure. And this explains why there is some redundancy in this paradigm of inflamed hot tumors being mostly the ones that express PD-L1. However, there are some reports about intrinsic mechanism by which tumor cells can upregulate PD-L1 even in the absence of interferon gamma or cytokine pressure. These are not extremely well documented, but apparently include strong oncogenic signaling such as PI3 kinase pathway and other that could actually upregulate PD-L1 in certain disease types. The majority of cases we see are actually those inflamed tumors with T cells, interferon gamma in the neighborhood, and upregulation of PD-L1. But then measurement of PD-L1 in tissue has been challenging because of the repertoire of assays, cut points, and sample types that can be analyzed. But there are some common principles that I think span most of the assays and most of the context. One of them is that we need to obviously use a validated IHC assay and proper controls. And this is important because the usual controls that are used in pathology and non-quantitative pathology are generally not very helpful. In this case, we need to have measurement or controls that can attest to the level and not only positive or negative. So generally, we recommend using a number of controls and not only one. A second important principle is that the sample should meet pre-analytical requirements. And this sounds obvious, but it's still a problem in some settings where samples are underfixed or overfixed, and that can compromise immunoreactivity or epitope recognition by the antibodies. A third important consideration is that we need to be aware of the tumor assay-specific differences. And this is critical because, as we'll see next, some PD-L1 assays are approved in certain diseases associated with specific drugs. So depending on the tumor type and the expected treatment, we might actually want to develop one assay or one scoring system over another. So understanding that is critical to be able to handle this correctly. Then PD-L1 is detected both in tumor and stromal cells. This had generated confusion because the initial assessments included only tumor cells, but it's clear now that every cell that is exposed to interferon gamma has the right to express PD-L1, and therefore somehow the contribution of PD-L1 by other cells can be captured. And then that membranous staining in tumor cells is generally what we see, but it can be cytoplasmic in immune cells. And this is important because a lot of this was sort of inherited from the HER2 era, which was probably the first or second semi-quantitative IHC scoring. And a lot of people got used to score only membranous staining, but when it's scored in immune cells, it actually can be cytoplasmic. It still counts as positive. So this is important to keep in mind. The intensity of staining is not considered. This is another difference relative to HER2 scoring or other semi-quantitative scoring. So we just score every cell with detectable membranous staining as equal. And then generally, we have to exclude areas with non-invasive disease, which is relevant more in certain diseases than other. But I will show you some examples of how this can be problematic. And finally, PD-L1 staining can be heterogeneous, and we see that particularly in certain tumor types. And the current answer to that problem is to integrate the scores from multiple different areas rather than using a hotspot approach where we just score the highest. So these are the major principles that guide PD-L1 assessment. And then this is the landscape of PD-L1 antibodies. They're listed here from 28A to 22C3. All of these have received some form of regulatory approval, but with different designations. Some of them are called companion, meaning that they're in the label of the drug and they're required to be tested to be able to use that treatment. And some have been designated as complementary, meaning that there is a benefit, the assay is standardized, but they're not in the label of the agent. What we have seen is that the scores and the type of scoring changes depending on the tumor type, and you can see here examples in lung, head and neck, gastric, and so on and so forth. But what has been interesting too is how dynamic this is, in which, for example, some FDA approvals have been now retracted, such as the triple-negative breast cancer, who is now not available, and that's why it's scratched in the slide. And then we have new approvals, for example, the approval for atezolizumab in the adjuvant resectable disease setting, which is now a 1% tumor cell assessment with an antibody called SP263, which was not the original companion of atezolizumab. So now we're seeing new indications, and now we're seeing one drug switching to another antibody formerly used by another drug. So it's really interesting how this is evolving, but it is there, and I think we need to adapt. And then the second layer to this is that each assay and disease context has a different way of scoring tumor cells. In general, the principles are the same, but there are some that are more popular in certain diseases than others. For example, TPS scoring or tumor proportion score is very popular in lung cancer, particularly with 22C3 assay. And it's just a reflection of the proportion of tumor cells that are positive relative to the whole population of cells. The second one that is highly popular, particularly outside lung, is the combined proportion score, which is essentially the number of PD-L1 stained cells, including all of the cells, divided by the amount of tumor cells. And this is very heavily used in the GI context and other disease types. And again, it captures both the tumor cells and the inflammatory cells. And then there is this division of tumor cell and immune cell that is typically associated with SP 142 assay, formerly associated only with atezolizumab, that includes either a proportion of tumor cells or an area of inflammatory cells. And I point this out because the inflammatory cell scoring is not based on a number of proportion of cells, it's actually based on the area, which can create some specific problems. So now, to give some examples of problems that may occur in the context of PD-L1 scoring, I selected a few cases from my practice to show examples. And a very, very common scenario is that both tumor and immune cells or non-tumor cells in the specimens can actually express PD-L1. And this is an example where you can see here tumor cells positive for membranous PD-L1, and then surrounding islets of macrophages also highly expressing PD-L1. This is actually normal and expected based on what I just told you, that interferon gamma is able to upregulate PD-L1 in every cell that has interferon gamma receptors. So this can be problematic when they're very admixed, and sometimes macrophages are difficult to distinguish from non-highly atypical tumor cells. So the usual solution here is just look carefully at the H&E, or even perform immunohistochemistry for cytokeratin or CD68 if there is any major decision-making point, particularly when this can be across the cut points. This is another example where this can be problematic. This is a largely negative PD-L1 tumor that you can see surrounding an islet of macrophages that are within the tumor nest. So this is quite problematic because the morphology of the cells sometimes is not very evident. So this actually will be a negative case with only positivity in those immune cells. So if we go by tumor proportion score, it would be negative. If we go by combined proportion score, it will not be negative. So these are the kind of things that happen. Generally, a good morphological assessment, zooming in and look at the nuclear morphology and the atypicality of cells, is enough to rule out that there are tumor, non-tumor cells, but sometimes it's challenging and we need to be aware of that. Another example of this problem is given here, where you can see this is a non-small cell lung cancer with focal areas of necrosis and then prominent immune infiltration surrounding those tumor nests. And you can see that within the tumor nest, there are these scattered positive cells with membranous reactivity, which could well be some macrophages and maybe some tumor cells. So really making a judgment in these cases becomes very challenging. And then again, look at the morphology carefully, and eventually, if necessary, you can do immunohistochemistry to try to resolve it. In general, the cut points are relatively loose, from 1% to 50%. So putting the case within those thresholds is not a problem, but it can be in the context of 0 to 1%, because 1% essentially means any positive cell. Another example are presence of necrosis that can actually bind non-specifically primary or secondary antibodies. So there is essentially non-specific accumulation of antibody and chromogen deposition on those areas. And you can see here a tumor with a central area of necrosis with a chromogenic signal focally. And then when you zoom in, you can see that those cells are not viable, as evidenced by the lack of nuclear morphology and content, and there is pigment deposition. The most important thing here is that we should not interpret this as positive, because it is a practice in pathology sometimes to see areas of necrotic tissue positive for cytokeratin to think that it was a carcinoma. But I think in this case, we cannot assume that this is a necrotic PD-L1 positive tumor. We can just let it go and assume that if there's not membranous staining in tumor cells, we should not call it TPS positive. And then this is another scenario that it's quite challenging, is that when we have a PD-L1 negative tumor surrounded or at the interface with the non-tumor tissue, which has all the right to have alveolar macrophages that are positive for PD-L1. So this is important because if we were using stromal scoring or immune cell scoring, we wouldn't know if to include these immune cells into the tumor site or into the non-tumor site. So this is clinical judgment, and essentially we have to be aware that at the interface between tumor and non-tumor region, there may be non-tumor areas that have PD-L1 expression, and they should not be included in the scoring. So again, this is a potentially problematic case. This is mostly applicable to breast cancer, which is not in the label, as I mentioned anymore, but it's also true for other diseases, which is only scoring the invasive component. And this is typical, that we have sometimes even multiple foci, where some of the foci don't have a clear invasive component. They should not be counted. This is an example of a DCIS around invasive carcinoma of the breast, and you can see here that there is some positivity in the immune cells surrounding this ductal carcinoma in situ component. This should not be included in the scoring, and that's the way so far it's being applied. Until we see data with use of immunotherapy in non-invasive disease, this should not be considered for scoring. And then this is another example now in the context of gastric adenocarcinoma where necrosis can generate some problems. You can see here this foveolar epithelium up here and then a focal necrosis here that looks pretty brown. When we look again at high power, we see foci of necrotic tissue with some chromogenic deposition, which is certainly not qualifies at PD-L1 positivity. And then also, sometimes, particularly in small biopsies, endoscopic biopsies that are compressed, it may be very difficult to discern what is a tumor cell from what is a stromal cell. And this is another example in gastric adenocarcinoma from an endoscopic biopsy where you can see PD-L1 staining in this area surrounding these epithelial glands, but then really telling if these cells are tumor or non-tumor to do a proper CPS scoring is actually very challenging. So here, I don't have much advice, just to look carefully and try to do your best. But sometimes it's very, very, very difficult to do. Finally, PD-L1, as I mentioned, can be heterogeneous. This is an example of a lung carcinoma where you can see an area of carcinoma that is dead negative for PD-L1, and next door is a highly positive area. In this case, we just have to integrate the scoring. And this is, again, to see that it doesn't always look membranous. You can see here that it looks membranous plus something else. So this can be challenging because discerning how many of these cells are actually membranous from the ones that are not can be tricky, but you have to do your best call. And then finally, another example of heterogeneity in the context of an endoscopic gastric biopsy. You can see here 2 fragments of an endoscopic biopsy, both containing tumor. But one of them only here in the upper fragment is actually positive focally for PD-L1, and the other one is dead negative. So this is another example of extreme heterogeneity even within the same biopsy. And the current solution is to just integrate the score. So we're going to move to the last part now, focusing on microsatellite instability, which, as we just heard, is a prominent biomarker, particularly in GI and GYN tumors. So the whole field of microsatellite instability relevance in the context of immunotherapy emerged from mostly studies by Luis Diaz and his team at that point at Hopkins, showing that this microsatellite instability positive or high tumors did actually derive a lot of benefit relative to non or MSS or MMR proficient tumors. And this actually was extended to multiple different tumor types, which actually derived ultimately in the agnostic FDA approval for every tumor type, even in kids. And this was actually confirmed in multiple studies, and this is one of such studies where the benefit of mismatch repair deficiency high tumors or microsatellite stability high tumors was shown in a number of different tumor types that you can see here, with overall response rates that range from 30 to high 50s. So this is actually quite prominent, and is the reason why now MSI testing became so popular and so extensively used. We actually went from doing very little MSI testing to now doing a lot just because of this. And this actually has also brought up some challenges. And one of those challenges is how to use microsatellite instability. Should we reflex test cases, or should we just select? Should we wait for the histology to be read and then request the MSI testing? Today, there are no defined guidelines on how to do this. What we do know is there are a few tumor types, specifically 3, that have very high rates of microsatellite instability, which are essentially uterine carcinomas, colorectal, and gastric, which are indicated here. And some institutions are prioritizing reflex testing on those 3 and not on all the others that have very low rates. However, what we're seeing in the clinic is that, in general, patients that progress and have advanced disease get MSI testing anyway as a way to potentially use immunotherapy. But then the other challenge is that this study, for example, that looked at thousands of microsatellite loci, so not only 5, which is what we look in the clinic, more than 200,000, actually found that between different tumor types, there are a number of differences in the number of loci that can be affected, which raises the question of maybe should we use different assays for different tumor types, or should the cut point be different? At this point, there's no data to support that we should do it, but there is the question, and we should be aware of that. And then the obvious question is how to test for microsatellite instability. There are two sort of main assays that we have been using for a long time. They're fairly well standardized. One is the 4-marker immunohistochemistry with this 4-IHC, which are typically read in the context of pathology. And they're relatively easy to use. They're widely available, and they have a number of advantages. So they're fast, they're cheap, and they don't require germline DNA. So they're very friendly for use. And their high sensitivity estimated to be about 85%. So this is really a good assay, and generally most institutions are starting with this immunohistochemistry. But then there is the PCR-based assay, which is a 5-mononucleotide marker PCR with capillary electrophoresis and 2 pentanuclear markers. And this test is highly sensitive. You can see that it's over 90%, so it's a little bit better than immunohistochemistry, but it's a little bit more complicated, not so available, and it also requires germline DNA, which is not always available. Sometimes there's a small biopsy and we don't really have non-tumor tissue to extract germline. So it is a little bit more complex. I would say that today these tests are complementary, and I think it's a common practice to screen using immunohistochemistry and then confirm using PCR molecular test. There is also emerging algorithms to detect microsatellite instability using next-generation sequencing. There are at least 5 algorithms that have been reported, but they're still not at the level of standardization that we need for use. So generally, it's immunohistochemistry plus minus capillary electrophoresis. And just are some examples of how that works. This is a perfectly normal colorectal carcinoma, which you can see it's nuclearly positive for the 4 mismatch repair deficient proteins, MLH1, MSH2, MSH6, and PMS2. So this is the expected MSS carcinoma. And this is a prototypical case of a microsatellite instability high case, where you can see that only MLH1 and PMS2 are negative in the tumor cells, but they're positive in the surrounding non-tumor lymphocytes. So this is a typical and one of the common patterns which we can identify microsatellite instability. Because life is not perfect, there are ambiguous cases, and we see them on and off. And this is an example of such case where you can see focal expression of MLH1 and very weak in some tumor cells, but not in other, and also the same with MSH2. The most important consideration in this case is rule out a technical error, just that the immunohistochemistry didn't work, or that the tissue may have a problem, under fixation, over fixation, or something like that, which can generally be QC'd by the other markers. So if the tissue was bad, all the markers would be negative. But in general, this can also reflect biology. Sometimes the mutations in mismatch repair genes are bad enough to compromise the function, but they're not bad enough to compromise the protein expression, or they can compromise a little bit. So not infrequently, these cases with aberrant or unusual staining patterns are actually the ones that have mutations in one of the mismatch repair proteins. So just keep an eye on that. And so now we're going to focus on tumor mutational burden, which is the last of the FDA-approved biomarkers. And this biomarker has been controversial in many ways because how difficult it has been to standardize. And to be very simple about what it is, a tumor mutational burden, is essentially counting the number of non-synonymous mutations per area of the genome analyzed. And the way it happens is that, as an example, we have a couple of types of mutations. For example, we have silent mutations, or what we call synonymous mutations, which are mutations that don't change the amino acid, so they're not included in the tumor mutational burden. And then you have missense mutations and nonsense mutations, which are the ones we typically consider deleterious, so they affect the amino acid sequence, or sometimes they even produce an early stop or truncation of the protein. These are the ones that are actually counted in the non-synonymous mutation tumor mutational burden score. And then there are a number of other genomic alterations that are generally not counted or counted only if detected, but they depend on different assays. So essentially, the definition is number of non-synonymous mutations detected per area of genome covered, whatever that area is. And there are a number of ways to detect that, and they really vary in the area of genome that is covered. I would say that the gold standard today is whole exome sequencing, which is essentially the whole coding region, about 22,000 coding region genes, and it spans about 30 megabases of sequencing. And it's actually very good at detecting all these mutations or coding mutations, but it's not very friendly to use because we don't really have great clinical pipelines to do whole exome sequencing, at least not everywhere. So it's not a great option to decide treatment. And then there are targeted sequencing panels. These are two that are FDA approved, Foundation and Impact panel. And you can see that they span anywhere between 300 to 500 genes. They cover around 1 megabase of sequencing, which has been considered to be on the low end of requirement. In general, we believe that around 2 megabases of sequencing may be enough to actually have a reliable tumor mutational burden call. But they have the major advantage that they are standardized, they're FDA approved, they're reimbursable in many cases, and they have a shorter turnaround time, which obviously helps clinically. So today, I think there are still questions about what is the right assay to do and how to actually access that assay. And the relationship between high tumor mutational burden and activity of immunotherapy agents has been well established. There are exceptions to those relationships, but I think in general we see that highly mutated tumors tend to be more sensitive than tumors without mutations. What is interesting about tumor mutational burden, when you think about it, is not a binary thing. It's actually a continuous metric. So we get a number of mutations. And then whenever we have a continuous metric, a big question is what is the right cut point? And this has been difficult to establish because, as you can see in this chart, there is a clear relationship between the number of mutations or cut point and the hazard ratio, with the highest number of mutations having the lowest hazard ratio. So that means that the upper the cut point, the better the benefit, but the fewer patients are positive. So the idea has been tried to balance a cut point that captures a lot of positive patients with a good hazard ratio, and that was established to be somewhere between 16 mutations per megabase and 20 mutations per megabase that have about a third of patients positive depending on disease context, and they seem to get the benefit. Again, the data is still quite controversial in some settings. But the most important point is that I want you to think about this as a continuous metric and not just as an on and off test. And then this has been validated, and this is some of the data that supported the, again, FDA agnostic approval of tumor mutational burden. And you can see here that across multiple different tumor types with actually quite different biologies, all the way from typical carcinomas to even neuroendocrine, small cell lung cancer, and thyroid tumors, there was a difference in the benefit of pembrolizumab in these patients that have high tumor mutational burden. So this, again, drove the approval, and it is a main reason why a lot of the people are requesting and using this tumor mutational burden assay. There have been a lot of discussion about how to harmonize and standardize tumor mutational burden. And this is an effort from the Friends of Cancer Research. This was actually published in the Journal of Immunotherapy of Cancer in 2020. But I took this slide from a presentation because I think it shows exactly what is the problem, which is that essentially these are the same data from TCGA analyzed by 11 different labs, and you can see high correlations in the number of mutations per megabase acquired, but they don't go in the 45-degree line. So they correlate, but the numerical value is actually different, and that can certainly impact the cut point. And the same thing happened when another TCGA layer was used, when cell lines were used, but also with clinical specimens. And you can see here that they all correlate, but they all deviate from the 45-degree axis. So with different tests, we'll get a different numerical value, and they may actually be across the cut points. So I think today we still don't know exactly how to standardize and report this type of assays. So now we're going to talk about the pathological response, and this is, as mentioned, has been really coming fast into our clinics because of the expansion in the use of neoadjuvant immunotherapy, and we just mentioned that there is a recent approval for immunotherapy combined with chemotherapy in lung cancer. In this case, to try to address this problem, the International Association for the Study of Lung Cancer, the Pathology Committee, which I actually am a member of, we essentially established some guidelines to try to harmonize and uniform the way the pathology assessment is being done, with the goal of first being able to collect data to understand how it's going on, and second, to be able to compare this metric with outcomes down the road. So at least we have something to work with, and then we can learn on top, rather than just using 5 different systems and then not being able to even learn. So this is kind of ongoing work, and we expect changes to this guideline to happen. But the fundamental principles of this is that there is this evaluation of the entire tumor bed. And this essentially includes locating the tumor bed, which sometimes sounds easier than it actually is to do, and then mapping the tumor bed to be able to establish 3 components: the viable tumor, the necrosis area, and the stromal area. And then all of them should add to a total of 100%, which reflects the entire tumor bed. So that's the way we should think about it. And then there is this pathologic complete response, which is 0 viable tumor cells, major pathologic response, which is less than 10% viable tumor cells. And so far, as I mentioned, it's recommended for use with any treatment: chemotherapy, targeted therapy, immunotherapy, or combinations. But it may actually be learned down the road that we should incorporate other factors, for example, for immunotherapy, where inflammatory components may actually be relevant. And to date, again, we report this with 10% increments. There is a call to call very small increments as single digits, but in general, we score it using 10% increments, and it's semi-quantitative. So it's not quantitative, it's an estimation, but really depends on how the tissue was mapped. And because of that, there have been a number of recommendations that I won't read, but they're available in the practice aid on how to locate the tumor bed, how to use anatomical references, imaging, and actually pictures to be able to correlate the grossing with the microscopy, and then how to sample the suitable area. There are a number of recommendations for small and large tumors, and essentially the question is how much we should submit from the specimen. Today, the principle is that the more the better, to try to not leave areas not looked at. And then there are also recommendations relative to the histologic assessment, how to define borders, how to record the histologic features, and determination of the pathologic response. One thing that is very helpful, that this recommendation includes a template that actually can be used to fill questions relative to the primary tumor, the lymph node response, and then other information that is relevant. My recommendation is that using a standardized approach in the institution and a template is actually very helpful to make sure that all the specimens are handled in a similar way. In that way, it's according to current principles. As I mentioned, there have been suggestions that in the context of immunotherapy, for example, additional immune features such as tertiary lymphoid structures, inflammation, vascularity, and other can actually contribute to the evaluation of the immunotherapy response. This study actually evaluated that, but this is still in the works, and I think for now we should stick to the standard designation until we know what are the differences between treatments and between histologies. There's actually suggestions that adenocarcinomas and squamous carcinomas may require different thresholds for major pathological response, but again, that's to be determined. Great, and now we'll close with a brief look at the future. So where are we going from here, and what are the things to keep an eye on? And there are a number of things going. One is refinement of biomarkers that we already know, for example, using tumor mutational burden, but now in blood ctDNA measurements, combining things like RNA measurements of inflammation with PD1 or mutations. We just mentioned the role of other immune inhibitory receptors, such as LAG3. Integration of biomarkers, I'll show a few examples, but there are novel things going. For example, there are a number of patient-based conditions, gut microbiome, HLA type, use of antibiotics, and other things that may actually affect response. So there is a lot going on and quite creative. This is an example of how combining PD-L1 and TMB may actually work. This is a study we published back in 2018 where we realized that TMB and PD-L1 were non-correlated, which means that they're orthogonal, they can be combined, and we saw high responses in patients that had both PD-L1 and high TMB. It's not usually the case, but when it happens, it can actually be a good marker. And then this is data from Checkmate 26, where you can see here in this survival curve that the patients with high TMB and high PD-L1 were the ones that derived the most benefit, in this case, to immunotherapy. So this is an example of how things can be combined. This is data from Merck published in different tumor types using pembrolizumab, and they also advocated for using a tumor mutational burden metric together with a gene expression profiling using the NanoString platform and 18 genes. And they also saw that inflammation and tumor mutational burden could actually do better than either alone, giving room to this. And then other possibilities are to use this in the context of multiplex immunofluorescence. This is some of the panels we're using actually at Yale. We're moving them to the clinic, including PD-L1 and immune cell markers, some of which have been shown to have value, so we can combine them and try to capture the information from all of them. There are a lot of questions, how to measure, how to score, and I won't talk too much about it, but if anyone has questions, I can address that later. We have published extensively on the expression of LAG3, PD1, and TIM3 as metrics of T cell dysfunction that have been associated with resistance to immunotherapy, but we have not been able yet to move them into a clinical grade biomarker, but there's certainly information to be used in the T cell dysfunction program. And this is an example of how that can be used. We published a few years back that FGL1 was actually one of the major ligands of LAG3. And now that LAG3 was approved as a therapy, we're thinking that maybe FGL1 could be a good companion biomarker, and we're actually looking for that. Finally, I will briefly talk about liquid biopsy. This is something that is quickly expanding. It's actually generally used to detect mutations, somatic mutations in periphery. It's actually very sensitive, but it can miss a lot of positive cases. And this has been shown in this study comparing tumor versus blood, where about 25 to 40% of cases were not detected in blood, but were present in the tumor. So we need to be careful. Mostly the problems are false negatives. However, it has been shown that ctDNA changes can actually locate response and be prognostic in the context of immunotherapy, and they actually precede the imaging. This is the number of days, actually. You can see that the ctDNA changes occur earlier than the tissue imaging. So it's potentially a rapid way, non-invasive way to monitor response. And this has been also been shown across different tumor types where residual ctDNA presence has been used to predict response, in this case in a mostly prognostic fashion, but it's clear that a lot of people are claiming for using ctDNA response criteria. So instead of only looking at the tumor, a dramatic drop in the ctDNA content could be potentially used as a metric of response to treatment, and this will likely happen in the future. People have tried to look at tumor mutational burden in ctDNA, but today the data is not very solid, so there's not a recommendation to use blood tumor mutational burden. So with that, we close, and we have essentially no time left, but I think we can take questions with the audience, and the speakers will remain here for a while. So with this, we close the program, and we thank everyone and people that are in their homes attending virtually for this great meeting. Thank you very much.
Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/KCV860. This activity is supported through educational grants from Bristol Myers Squibb and Merck & Company Incorporated.